Hey everyone, my name is Dr. Cole Hague, and I'm a pediatric clinical neuropsychologist at Mass General Hospital's Psychology Assessment Center. I just wanted to say before I launch into my presentation here that I'm so grateful to be here with you all today. I love not only just working with our patients, especially patients that have rare conditions such as Myrie, but also I also really love the opportunity to get to speak to parents, caregivers, additional family members, as well as support staff, other clinicians, people in the special education realm. I really love the opportunity to get to speak to you all as an opportunity to really sort of be where the rubber meets the road, right? And so this is, I think, in my opinion, where I really learn quite a bit and also feel just that kind of inherent reward in being able to work with folks in a more collaborative fashion and speak to you all and answer some of your questions. So thank you again for this really, truly wonderful opportunity. Before I get into some of your fabulous questions that you sent me, and they were really wonderful and insightful, I wanted to give you all some background information on neuropsychology and neuropsychologists, both in the adult and the pediatric world, just as a way of being for lack of a better term, sort of an informed customer as you are seeking out an evaluation from a neuropsychologist. I often find this is stuff that my patients ask for and really want some additional information or time spent kind of discussing these things as a way to really empower them to make some really good decisions about their care or the care of somebody that they love. So I thought this would be a really good opportunity to maybe go through that. So starting off with just sort of what is neuropsychology, what's frequently referred to, as clinical neuropsychology. So clinical neuropsychology or neuropsychology, I'm just going to sort of refer to it as that throughout here. So it's a specialty field within clinical psychology that emphasizes understanding the relationship between brain function and behaviors that we see in our patients or our clients, right? And so that's more of a clinical answer to something that I frequently get a question about, usually in the early stages of evaluations with many of my patients. So I like to break the word down a little bit. So I have neuro and psychologist, right? So neuro obviously means brain. And so what that means is I am interested with my patients, how they are thinking, how they're learning, how they're getting around in the world. One of the things that I frequently say, because I truly believe it, everybody learns differently. Right? Everybody has a different learning style. And for that, for a lot of the patients that I work with, what I'm trying to figure out is what that learning style is and how to maximize and support somebody's learning and ability to kind of function in the real world. So that's the neuro side, right? Then we have psychologists, and obviously psychologists are more interested in how you are feeling, how you are behaving, how you're getting along with your friends and your family members, how you're kind of managing, your feelings of self-efficacy, things that you're good at, So that's also a component of what I do, right? So neuropsychology is really sort of a perfect merging of both of those interest areas, and that's the focus of my evaluations. I think another question that I frequently get is, who needs a neuropsychological evaluation? And then also within that is sort of the adult versus pediatric neuropsych evaluations and what that looks like, right? So a lot of folks that we see, really all of the folks that we see, have either some sort of chronic issue that they're managing, or it could be more of a series of new complaints that have maybe emerged or something like that, right? So a good example of that would be folks with Myrie, right? So a neurogenetic condition that a lot of our folks are identified with maybe early on in their lifespan, and then it's going to be something that they manage over time, right? We often see folks with medical or neurologic conditions, and that includes things like epilepsy, dementia, genetic disorders. Commonly, what we see are folks with things like Down syndrome or Fragile X. We also see folks that have developmental conditions, and that would be like your ADHD or your autism spectrum disorders, learning disorders or learning disabilities are sort of colloquially referred to. We also see more acute conditions, right, that I mentioned. So things like concussion, right, and it could be stroke. So things like that are also populations or conditions that we frequently see in our offices. So as you can probably assume that on the adult side, you're seeing things more in the realm of, say, dementia or Alzheimer's, Parkinson's, brain tumors or cancers, and they're associated, and how their treatments have impacted the cognitive functioning of our patients. But you see many others, right? Common referral questions are things like, changes in memory, changes in kind of handling day-to-day activities or tasks. But they can obviously include things like emotion or behavior changes, right, as well. On the pediatric side, which is the world that I live in, so we commonly evaluate folks with more typical pediatric conditions, so things like autism or ADHD, learning disorders. Prematurity is a big one, as well as conditions that we're also talking about that are really understood, I think, even from sort of a public perspective here, as being conditions that we're managing kind of across the lifespan. So things like late effects of cancers are also under that umbrella. Epilepsy, stroke, genetic conditions, among many, many others. The most common referral questions, I think, for us are difficulties with, say, attention or executive functioning, processing speed, speech language, pretty common as well. Motor functioning, that includes both fine motor as well as gross motor. And then academic concerns, like, of course, right, big component of what pediatric neuropsychologists often hear from patients and their families is that there are academic struggles that they may be experiencing. But then emotion and behavior changes are also a big component of the referral questions that we usually get from our patients and our families. So who needs a neuropsychological evaluation? So you can probably infer that the folks with the aforementioned conditions that I mentioned are at the greatest risk for neuropsychological deficits, and thus are at greatest need for neuropsychological evaluations. But we also get referrals for many conditions that can be diagnosed or evaluated by some psychiatrists, and that includes things like ADHD, mood or anxiety problems, and a few others. So I think the reason that I bring this up is because I think it's best to sort of talk with a pediatrician or a primary care provider first and foremost before you go and just kind of go in cold to sort of a neuropsych evaluation and say, hey, I think my kid has ADHD, right? And I think that should be sort of what we evaluate here. I'm certainly not saying that folks with ADHD don't need neuropsych evaluations, but I do think that there is sort of a hierarchical process throughout here, and oftentimes I hear about families saying, what I really wanted was, some recommendations for behavior therapy, as well as, medication to treat my kids' ADHD. It's been pretty clear to us, it's pretty clear to teachers. And so for those reasons, I feel like oftentimes I'm sending them back to psychiatrists and saying, hey, I think, these are the next steps for this kiddo, right? And so one of the biggest concerns that I have as a neuropsychologist is making sure that people get treatment immediately, because usually as part of our evaluations, right, what we do is we don't just evaluate the cognitive skills of many of our patients. What we do is provide intervention plans or recommendations, as you will see in the reports, that say these are sort of the next steps which we think the person or the family should be taking in order to get the treatment that they really need. We're diagnosticians and ultimately consultants, and so it's important for us to be able to tease out what are sort of the areas that really need intervention as part of our evaluations, and then refer people back to the appropriate providers to get the requisite treatment, or the treatment that we think is going to be most beneficial for them. So what you should look for in a neuropsychological provider, this one I think is really, really important. It's something that we don't talk with our patients enough about, right? So if you're pursuing an evaluation by a neuropsychologist, either in the adult or the pediatric sphere, it doesn't matter which one, it's really important to check the provider's credentials. They should have a doctorate in clinical psychology. Sometimes you'll see folks that have doctorates in school psychology, which is also great. But what you're looking for is a PhD or a PsyD behind their name, certainly. But most importantly, they should have completed a 2-year fellowship. They should have done an internship in neuropsychology as well, but it's really important that they have done a 2-year fellowship in neuropsychology, right? Those are sort of the things that we as neuropsychologists really think of when we are evaluating other neuropsychologists' competency to be evaluating or providing services to our families, right? They should have attained or not they should have attained, some of them may have attained also a board certification. So you'll see that signified by the letters ABPP behind their name, which is the American Board of Professional Psychology. And that would be a specialization in neuropsychology, a board certification in neuropsychology that really is just further evidence that this person has gone through the board certification process. They're really, really qualified neuropsychologists. So you would see that ABPP behind either the PhD or PsyD credentials of a person's name. So those are just some of the helpful sort of tips and things that I think can be really important for our patients to know and be armed with, kind of walking into the room or determining whether or not they want to receive treatment from one of these neuropsychologists. So with that overview, one of the things I wanted to do is now just kind of go to the important part here, which is answering your questions, which again, wonderful questions. I really, really enjoyed them. So I think let's start off with the first one, which was, should neuropsych testing be a standard test for Myrie syndrome? And I'll give you sort of the quick and dirty answer, which is absolutely, absolutely it should be. So as I mentioned before, for folks with neurogenetic conditions are particularly at risk for neuropsychological deficits. Now, to say the neuropsych literature on Myrie syndrome is limited would be an understatement, right? It's pretty much non-existent in many ways. But what we do know from sort of the anecdotal evidence from what I have learned working with patients with Myrie is that they are at greater risk for cognitive problems as well as general learning issues, right? But we do see quite a range when we're working with folks with Myrie, right? So I do think that they should receive routine evaluations. Those routine evaluations would be every 3 years, really, is what we're thinking. Beginning usually, if we can, when they're young, in order to track the progress of that specific person over time and facilitate their growth in the best way possible, you know, making sure we're keeping an eye on a lot of their skills, how they're developing, and providing appropriate and tailored intervention plans for them over time, right? And making those appropriate adjustments given the changes in development, but also the changes in expectations of their real world kind of context, right? How often should these evaluations take place? Well, I sort of inadvertently answered that in my last one. So really a routine kind of evaluation schedule would be about every 3 years to track progress. But for some individuals that may have more acute needs, or there might be these conditions that might change or fluctuate in terms of severity or presentation over time, you know, we can certainly see them sooner, right? So there are some folks that I see every 1 to 2 years, given their conditions would put them at greater risk for regression in some areas. But also, you know, we can see patients for more acute needs, like things like a family pursuing guardianship or decision making for a child, or somebody that's sort of on the precipice of young adulthood, somebody who's about to turn 18, right? Or say in another context where It would be maybe pre or post brain surgery or treatment for a certain condition. So those things are certainly, or those sort of scenarios are certainly ones in which we would see patients more frequently or under that sort of 3-year mark. For my patients, I also offer some more acute follow-up evaluations for children's that might, as I said, involve fluctuations or changes in functioning over time. So I tend to keep a pretty open communication pathway with a lot of the patients that I work with, simply to say, hey, something like third grade or fourth grade's coming on. Or coming up for this kiddo. And so I want you to get in touch with me if, say, what you notice is that, Johnny is really struggling with things like reading comprehension, or is really struggling kind of putting his ideas on paper or putting things together. And it seems like that integration of learning is really the area that's becoming more challenging for them over time. So in those scenarios, right, with those patients that I know might be at greater risk, and also when I have, more of an open line with the family, what I begin to notice is people may get in touch and say, hey, is this typical? Is this not so typical? And I'm more than happy to kind of spend some time either providing my insights and then, depending on kind of what's going on, offering them maybe a neuropsych evaluation a little bit sooner, like at 1 to 2 years instead of 3, right? What behavior is indicative of an evaluation? And so one of the things that I wasn't sure of here, exactly what you're asking, right? But I think I understand a little bit here. So typically the behaviors that we see, like I said, that are areas of the most concern to either our patients or our families, are difficulties with attention or executive functioning. And you've probably heard that term before, but it's really an umbrella term for how do I make it through the world successfully, right? So it involves a lot of different skills that include, say, emotion and behavior regulation, calming down, making sure you're not jumping in too fast, being impulsive, being too high activity, etc. But it can also go to more of the higher order cognitive skills that include things like planning and organization and keeping information in your head as you're kind of working through a problem. It can include, problem solving, right? Like, how do you take a novel situation or a task, sit down and try to puzzle it out or figure it out, right? Being flexible is also an adjustable to sort of demands or changes in demands. Is also a big component of executive functioning as well. Obviously, in the adult sphere, definitely you hear a lot of memory concerns, right? Or learning concerns, retaining information, etc. In the peds world, obviously the academics, the learning issues are pretty robust. That's a common concern that we really hear from a lot of our families or our educators as well. Speech language problems we hear about a lot, fine and gross motor skills as well. And so those are types of the behaviors, I guess you would say, or some of the things that most of our families really describe some difficulties with. It's the reason that they sort of walk in the room in the first place. If you're kind of wondering what an evaluation looks like, so they can range in terms of the time that they take. So some places, like myself, so I have sort of a personal philosophy in trying to keep things, answer the referral question, but also keeping things relatively brief, because we have, an array of neuropsych tests, not all of which I think always need to be given to our patients, but that's my own personal philosophy. So I try to keep my evaluations to about 3 to 4 hours, which in the neuropsych field, especially on the ped side, is pretty short. I wouldn't expect that from a lot of other providers, either at hospitals, but particularly in, say, private practice. So there you're probably running into an evaluation that's anywhere from 7 to 8 hours. It involves, having a lot of our patients, give us some information verbally, write some things, maybe do some memory testing, right? But things that we're also looking for is attention and that executive functioning piece. We're also looking at, we're having them look at pictures and give us, the words for those pictures, right? Or engage in nonverbal problem solving. So really, what that's looking like is you're working after about a 45-minute conversation that's addressing kind of what the patient was referred for, what the family or what the person is looking for with respect to the outcome of the evaluation, what are some of the challenge areas, what they'd like to see in terms of recommendations, etc. After a conversation like that for about 45 minutes, which we call a clinical interview, then the patient would work closely with the neuropsychologist for about can range from 2 to 3 hours to all the way to 6-7 hours, right? Then there's a feedback session after that that's usually between a half hour and an hour, where you're discussing the results, discussing the implications of the results, as well as going through any sort of diagnoses that you might be giving and providing that intervention plan I mentioned, which is just sort of a very long list of recommendations. Oftentimes our families then, especially again on the ped side, they take them to educators and say, hey, my kiddo just went through a neuropsych evaluation, and so what is here is the recommendations that this neuropsychologist offered us, and I would like their educational programming updated with that in mind. So I hope that I tried to sort of tackle the question in a couple different ways, sort of what evaluation looks like, and then also kind of what are some of the behaviors or presentations that are concerns that we usually see for our patients. I hope that answered your question. The last one that I got is, what about the Myrie syndrome diagnosis is most essential to communicate to educators? So for example, at IEP meetings, for those who are US based, I love this question. I think it's phenomenal. And actually it's where I spend a lot of time kind of going through some of the results of the evaluation. And especially when I'm talking about the intervention planning, thinking about how somebody's educational programming should be updated according to sort of the results of the evaluation, right? So I think this is really a wonderful question. I routinely kind of walk through the process for IEPs and how and what families should be doing, right? So again, I tell them to take the report. I empower them to sort of do whatever they want with the report, right? They're under no, the families that I work with are under no strict adherence to give the report to the school if they don't want to share it, right? But I often tell them to do it just because I think that there might be some recommendations that sometimes the schools don't necessarily think of that neuropsychologists have special training in, right? So I tell them to take it to the school. The schools then have 30 days to review, at least in Massachusetts. It kind of depends on where you live. They might have 45 days, they might have 60 days, right? But they have a discrete amount of time in order to review the report and then schedule a meeting with the family to touch base about how they're going to adjust the child's educational programming based on the recommendations that the neuropsychologist provided. Unfortunately, no school is under any obligation to do what we say, but I'm not saying that they don't typically. I typically receive relatively limited pushback from schools. So anyway. So I think first and foremost, the thing that I tell, so I primarily work with folks who have rare neurogenetic conditions. I also see folks with epilepsy, but I'm really in that sort of medical neurological world, right? That's primarily who I see being a pediatric neuropsychologist. And so what I say routinely is that the way that we need to conceptualize this person, especially with respect to their educational programming, is that first and foremost, they have a medical or neurologic condition. So in the case of Myrie, right, this is a neurogenetic condition. This is a genetic condition that has functional implications for somebody's cognition, their adaptive skill development, or their skills of independent living, right? Speech and language, their gross and fine motor, their learning, can be also their attention, as well as their social engagement, right? And so I think that there are lots of things here that we really need to be attentive to. But first and foremost, it's important to conceptualize these folks as having a medical or neurologic condition, and any of the deficits or difficulties that we identify with them are downstream of that, right? Or in more of a clinical term, they're associated with the condition, but the first and foremost sort of primary diagnosis or label that we should have in our educational programming would be that medical neurologic within the context of Myrie syndrome, right? So even though we see things like autism spectrum disorder, developmental delays, intellectual disability, learning problems, attention and executive functioning deficits, those things again are sort of secondary or downstream. They have more to do with the functional implications of Myrie, right? Like I said, when establishing the IEPs or 504 plans, it's important the schools classify them first and foremost as being an individual who has a genetic condition such as Myrie, and then that, you know, if they have an additional condition like autism or ADHD, it's important for those things to be labeled then sort of thereafter, right? More generally, I spend a lot of time telling parents and teachers and special education teams that we can't just use sort of a one-size-fits-all approach to creating the treatment plans for our folks, especially folks that have these really rare conditions, right? They need to really understand that these presentations, that the presentations of these conditions, you know, can really vary from person to person, right? And so the primary reason that I am most concerned with saying first and foremost they're somebody with a genetic condition, right, is that I don't want them to look at my patients and say, oh, yeah, I know he has a genetic condition, but really the way that we should be providing services is sort of through the lens of autism, right? Or through the lens of ADHD, or through the lens of somebody with developmental delays, right? I've seen that happen sometimes. It doesn't happen all the time, but in those cases where it is, it becomes very, very important to outline that this is a medical neurologic condition that has an impact on all these other functional domains like attention and executive functioning and learning and motor functioning, etc., right? And so, like I said, that remains particularly important for these rare, pretty understudied genetic conditions as well. So I think that's some important information for parents to kind of have in their back pocket as they're advocating for their kids at those IEP meetings. I think it's also something that you can ask, and not every neuropsychologist offers this. But see if they would be willing to, if that neuropsychologist would be willing to come to the IEP meeting when the patient's educational programming is being updated after the family has provided the school with the IEP, or not the IEP, excuse me, with the neuropsych evaluation report, right? And so I do feel like that can be something that can be really helpful, to have a face behind the paperwork or the documentation, the report, to be able to say, hey, you know, I'm here. I see this as sort of a collaborative enterprise. Let's put our heads together. I saw these things in the evaluation. I think that these things are going to be, these sort of recommendations or interventions are going to be really, really important for this kiddo. And I, you know, could we maybe sort of adjust the plan accordingly, right? Having somebody there with a little bit more experience on how to navigate and advocate for the specific needs of a patient, especially one that sort of is a discipline that is frequently sort of in contact with special educators and service providers, I think can be really, really beneficial. So I do that frequently for my patients, and I find that usually it helps to ultimately make sure that the kids get what they need in school, but also really helps parents and caregivers and additional folks who are supporting this patient or this kid feel really heard or understood, or like they're not just kind of alone, awash in a sea of people that are telling them exactly what they think would be best for them. So it's nice. I think that some of our patients feel like we're in their corner in those circumstances. So that can also be something that you certainly ask for, especially towards the end in the feedback and evaluation. So I've been talking for quite a bit, and so I want to just thank you again for the opportunity to be here. I hope this presentation has been helpful. I hope it helps you all feel like you have some resources in your back pocket or some information in your back pocket. So again, you can be an informed customer, but also, you know, to help really advocate for the specific things that we know you or your family or you know, other providers really need for you know, the people that we serve and for the people that you all love and care for on a daily basis. So anyway, if you have any additional questions and you would like to get in touch with me, please reach out to the coordinators of this meeting or this conference so that they can put you in touch. I'd be more than happy to field some additional questions or provide some additional information if that would be helpful. Thank you again. It was wonderful being here.